Ladies and gentlemen, and Chairperson, thank you very much for inviting me to a Latin American HRS meeting. It's a great honor for me to give a talk at this meeting. I'd like to talk about ethanol ablation for refractory arrhythmias, combining vein non-martial ablation with cryoablation for AFib. This is my COI. This is the city of Yokohama. First of all, I'd like to talk about transcoronary arterial chemical ablation first. Pedro Brugada first published this case report to treat ventricular tachycardia in 1989. I worked on the chemical ablation at Brigham and Women's Hospital long time ago. I published this paper, and this patient suffered from acute coronary syndrome, and VF occurred repeatedly. We found a culprit lesion to feed the focus of this VT, and we infused the ethanol of 50% in a slow fashion. This control VF occurred repeatedly. However, after performing chemical ablation of VT, even though the triggering arrhythmia occurred, VF could not occur anymore. We published a review article of alcohol ablation for tachycardia therapy. We injected ethanol into the AV nodal coronary arterial branch. We were able to create a complete AV block transiently, and the AV nodal conduction was modified afterwards. So let's talk about the Marshall vein. We classified the anatomy of the chemical Marshall vein. In approximately 12%, Marshall vein is absent. We performed a histological study utilizing porcine heart. We injected the ethanol into the coronary vein, and take a look on this. Small arterial branch was preserved from injurious effect, and this is a lesion created by the ethanol infusion in the coronary vein. The lesion is very well demarcated and homogeneous. Let's talk about triggering arrhythmia arising from Marshall vein area. We had interesting cases. This patient had premature atrial excitation arising from Marshall vein area in a bigeminal fashion leads to the AFib occurrence, as shown here. We performed the ethanol infusion into the Marshall vein, as shown here. After infusion start, at the end of the infusion, PAC has gone and AFib did not occur anymore. With the current mapping, voltage mapping system, we were able to create this small damaged area. And let me introduce our chemical ablation experience at my institution. We have already performed chemical ablation of vein non-Marshall in 560 cases up to now. Let me introduce chemical mapping utilizing Orion. We position the Orion catheters endocardially along the Marshall area. We infuse a shibenzoline of antiarrhythmic agent into the Marshall vein. Take a look on the electrogram recorded through the Orion catheters. After administering a shibenzoline, atrial electrogram during AFib has changed, well organized, and the cycle length seems to be significantly prolonged. In other patients, after administering shibenzoline into the vein of Marshall, atrial electrogram has gone, as shown here. So this study result means shibenzoline infusion into the Marshall vein could predict the clinical effect of infusion of ethanol into the Marshall vein in advance. Let's talk about time course lesion formation. Utilizing a NAVEX system control, immediately after the infusion of ethanol into the Marshall vein, we were able to create the damaged area, low voltage area, as shown here. When we waited 90 minutes, the damaged area significantly expanded, as shown here. This figure shows the time course lesion formation. This is a control. 30 minutes after injection of ethanol infusion into the Marshall vein, when we waited 19 minutes, the volume of lesion has significantly increased, as shown here. This patient had a recurrence and underwent a reduced AFib ablation session. This is a voltage map obtained at the first session we were able to create a long conduction block area by performing the ethanol infusion into the Marshall vein. After 6 months after first session, at the reduced session, the conduction block property of this area could be maintained. Let's talk about mitral isthmus block by chemical ablation of Marshall vein. This is a control voltage map. After performing the chemical ablation of Marshall vein, we were able to create a long damaged area along the Marshall vein area. This is mitral annulus. This activation map during the pacing from the left atrial appendage. We were able to create a long conduction block along the Marshall vein area. This is a propagation map during the left atrial appendage pacing. As shown here, we were able to create a long conduction block area. How about premitral flutter? This patient underwent a PV isolation 4 months ago and suffered from atrial tachycardia, as shown here. Utilizing current mapping system, activation map shows the counterclockwise rotation along the mitral annulus. After performing the chemical ablation of Marshall vein, we were able to create a scar area along the Marshall vein area, as shown here. We infuse ethanol into the Marshall vein. After administering the ethanol, perimitral flutter could be terminated, as shown here. Let me introduce other interesting cases. PHE triggered from the Marshall vein area. As shown here, we infuse ethanol into the Marshall vein. After infusion of the ethanol into the Marshall vein, AFib also could be terminated, as shown here, and the sinus rhythm resumed. Let me introduce other interesting cases, saying killing two birds with one stone. This patient suffered from not only AFib, sustained AFib, but also perimitral flutter. After performing an infusion of ethanol into the Marshall vein, we were able to create a long damaged area, as shown here. First, LSPV and LAPV could be isolated by performing the chemical ablation of Marshall vein, as shown here, and then perimitral flutter could be terminated, as shown here. And nextly, let's talk about isolation of posterior wall of left atrium. We performed the cryoablation of AFib in 2,040 cases up to now. We applied the cryoablation for PV isolation for pulmonary veins. After that, we tried to create the roofline conduction block by cryoballoon. First, we positioned the cryoballoon at RS, freeze, and move a little bit toward the rightward, freeze. We position cryoballoon at LS, freeze, then moved toward the rightwards a little bit and freeze to construct a roofline conduction block. And regarding an inferior line conduction block construction by cryoballoon, we position the cryoballoon at LIPV, freeze, and a little bit moved toward the rightwards, freeze. Then we position the cryoballoon at RIPV, freeze, and a little bit shifted toward the leftward, freeze. By this procedure in the controlled PV isolation, we were able to isolate posterior wall. Let me introduce other cases in the control. After applying the cryoballoon for isolation for pulmonary vein and roofline creation, inferior line conduction block creation, we were able to isolate left atrial posterior wall, as shown here. We performed a rapid ventricular pacing to enhance the freezing effect of cryoballoon. In this case, nadir temperature of cryoballoon reached plateau at minus 34 degrees Celsius. After performing the RVP, the nadir temperature of cryoballoon further reduced by 8 degrees Celsius, as shown here. In this patient, first we performed chemical ablation of vein of Marshall, and we were able to create a damaged area, as shown here. However, we found a gap around this space. And after that, we position the cryoballoon at this area as shown here. We freeze, and then we were able to create a long conduction block along the mitral isthmus area. And this finding was ascertained during the left atrial appendage pacing. As shown here, CS atrial sequence was changed, as shown here, indicating a conduction block area could be created at this portion. Let me introduce other cases. We position the cryoballoon at the mitral isthmus area first, freeze, and then moved a little bit upward, freeze, and move a little bit upward, freeze. By this procedure, we were able to create a long conduction block line along the mitral isthmus area. Solely by cryoballoon application, however, success rate is 50%. Finally, let me introduce our latest study. We performed only RF ablation in 90 patients, only cryoablation in 120 patients, RF ablation combined with chemical ablation of vein and marshal in 80 patients, cryoablation combined with chemical ablation of vein and marshal in 52 patients. No significant difference regarding clinical characteristics in these patients. When we draw the Kaplan-Meier curve regarding freedom from recurrence of AFib, comparison was performed between the group combined with chemical ablation to the without chemical ablation. There is no significant difference in terms of freedom from recurrence of AFib. Follow-up longer than 400 days. However, when we compare the four individual groups, we found a significant difference in terms of freedom from AFib recurrence. The best group was found in cryoballoon combined with chemical ablation, as shown here. When we performed the long-run test, take a look on this. RF combined with chemical versus cryo combined with chemical. We found a significant difference between both groups. This result means cryoballoon ablation seems to be superior to RF ablation. And when we performed the Kaplan-Meier analysis curve regarding persistent AFib, only RF ablation combined chemical ablation, we found no significant difference between both groups. However, regarding persistent AFib patients, only RF compared to the only RF ablation groups, RF ablation combined with the chemical ablation of vein and marshal was able to provide significantly better clinical outcome, as shown here. Ladies and gentlemen, let me conclude. Ethanol infusion into the vein and marshal could be performed safely. EIVOM seems to be effective to create a lesion at the mitral isthmus area. Finally, EIVOM seems to be useful to treating persistent rather than paroxysmal AFib when combined with cryoballoon application. Thank you for your attention. This is my hospital.